I'm Dr. Dilip Kapur. I'm an anaesthetist by training. I trained in anaesthesia in the UK, but I also worked in pain medicine in the UK. I came to Australia in 2002 and have worked in both anaesthesia and pain medicine in Australia. I work full-time in pain medicine now. I'm a fellow of the College of Anaesthetists, and I'm also a fellow and dean of the Faculty of Pain Medicine. I work in South Australia. I work both in metropolitan Adelaide and also across in rural South Australia in Port Lincoln. All my work is in chronic pain, and in my rural practice I also work with a First Nations health practice. So I have a broad variety of clinical practice in some wonderful settings. Anaesthesia and pain medicine have been together right from the start, and you might even argue that pain medicine preceded anaesthesia, but anaesthesia was necessary because of important gaps in pain medicine. So if we go back to the early days of surgery, and this was generally done in the context of military injuries or other causes that would really lead to the one operation that people did at that time, which was amputation. Then if we go to the 18th century, no anaesthesia, the best that could be done was to provide large amounts of intoxicants and an analgesic, something in the form of opium, and you'd end up with a patient who was not anaesthetised, but was certainly stuporose. Even with that level of what we might term pain relief applied, an amputation would be utterly awful. And there are horrible descriptions of what went on. So when anaesthesia came along, of course, it completely transformed what could be done in these big and very traumatic surgical operations, but also what could be done in much more subtle settings. Anaesthesia then has an interesting backdoor link into pain medicine, because a number of early anaesthetic agents are also very powerful pain relieving agents in some anaesthetic concentrations. So when chloroform was discovered in the 19th century, it very rapidly became clear that in addition to being an anaesthetic agent at relatively high doses, chloroform was a very powerful analgesic agent in low doses. As we move into the 20th century, we start to look at other things that developed where there was a big overlap between anaesthesia and pain medicine, and in particular with the increasing use of regional anaesthesia techniques and an improvement in the access to local anaesthetic drugs. It became clear that very useful pain relief could be provided with these drugs that took things well beyond the pure anaesthesia setting. So, for example, local anaesthetics could be used for management of pain associated with things like burns and dressing changes and so on. And then, as that progressed, we became aware that local anaesthetic techniques could be used in settings of extreme pain completely outside the surgical environment. So, for example, in some types of cancer pain, local anaesthetic blocks could be very useful, and then that was extended into what we call ablative blocks, where a nerve trunk is actually destroyed. So, looking across the spectrum, we see that anaesthesia and pain medicine have walked side by side right the way from the start, and there's no indication that we're going to be separated at this stage. I trained in anaesthesia because I loved anaesthesia. I remember doing my anaesthesia module as a medical student, and it was fascinating and it was fun, and anaesthetists were nice people. So I went into anaesthesia training after I'd done my interns jobs, and then worked in ED for a while. And in anaesthesia, I was always particularly interested in the acute pain relief side, and that involved both management of acute surgical pain through things like patient-controlled analgesia and opioids, but also through regional anaesthetic techniques such as epidural analgesia and regional nerve blocks. Now, like a lot of people, including our founder, our great late founder, Professor Michael Cousins, my interest in regional anaesthesia sort of drew me into the subacute and chronic pain side. I first got interested in the management of vascular pain, so that's pain associated with damaged blood vessels. And in particular, we would often see these people who the surgeons were wondering whether they would need to proceed to amputation. They'd try everything with them before that. But having an ischemic limb with inadequate blood flow to the periphery of the limb is often extremely painful for people. And I became really interested in looking at the use of nerve blocks in pain management in these people. That's through my work as an anaesthetist. And with the surgeons, we formed a really good working relationship, because the surgeons were very happy with what I was doing, because they had patients who weren't sedated with the larger doses of opioids that they would otherwise have needed. And additionally, the surgeons could actually watch and see how things developed in a limb over a longer period of time than might have been the case with opioids and the necessity to make a decision because of poorly controlled pain. So I became really interested in that, and then that took me into other areas of subacute pain, including some orthopedic pain. And I moved from there into longer-term pain management. Now, one of the problems that you have with longer-term pain management is that all these techniques that work really wonderfully in acute and even subacute pain tend not to work very well in chronic pain. So I found myself at a bit of a crossroads. And what do I do at this crossroads? Do I just say, okay, that's too hard? Or do I say, I need to learn how to manage this? And that's what I did. And it's a bit like the old Robert Frost poem. Two paths diverged in the wood. I took the one less followed, and that has made all the difference. Being in safe hands is incredibly important for patients. But one of the things that I recall as just good medical practice was what I learned as an anaesthetist, and that's going and seeing the patient beforehand, letting the patient know that you're taking an interest in them, and you're not ticking boxes. So listen to what the patient has to say, be careful, you hear what the patient's worried about, and you allay their fears as best as you can, explain to them what's going to happen. And then there's another part of this. The fact that they've seen you beforehand, perhaps in your civvies or something, and then they see you in the operating theatre, and you're still the same person, still jolly, reassuring. That's a really important thing for a patient. And then afterwards, an incredible thing for patients was when I used to visit them post-operatively on the ward, and explain to them what had gone on from my side of things. Now that is just simple good clinical practice.